My name is Imelda McDermott, and I will be presenting on conceptualization of skill mix comparing theory and practice. I would like to acknowledge my team members and my co-authors here. So this is part of a 2-year study funded by the NIHR exploring the scale, scope, and impact of skill mix in general practice. Just put a disclaimer here that the views expressed here are of the authors and not of the NIHR or the DHSC. Skill mix policy was first mentioned in the General Practice Forward View, which was published in 2016. The GP Forward View claimed that the workforce crisis in the NHS was due to years of underinvestment in primary care and suboptimal recruitment and retention of GPs and nurses. The GP Forward View was published to set out how to achieve a strengthened model of general practice. It stated that greater use of skill mix will be key to releasing capacity. Skill mix is used here to refer to a broad range of healthcare professionals, such as advanced nurse practitioners, clinical pharmacists, physician associates, physiotherapists, and paramedics. So put together, the policy document infers that non-GP from a broad range of healthcare professionals will be taking on the task of GPs to release GPs' capacity. In the literature, skill mix has been conceptualized in terms of competencies and practitioners. So competencies refer to a range of skills that an individual worker possesses. Practitioners refer to two things: the ratio of staff within a particular discipline and the mix of different types of staff in a team of healthcare or healthcare setting. Policies that refer to skill mix change are based on the assumption that competencies are not ring-fenced to particular professions and that tasks traditionally conducted by one profession can be conducted by another if they have the required competencies to perform the task. Based on this conceptualization, when skill mix changes have been referred to in the literature, it has been discussed in terms of role modifications. Using the terminology of competencies and practitioners, change is achieved through developing the competencies of practitioners to enable enhancement, which is extending the scope of practice within their own professional role, substitution, taking on the task of another professional group, delegation, tasks that can be delegated to others in the professional hierarchy, or innovation, becoming a new type of practitioner who has a new set of competencies designed to address specific needs. What we found from our current project exploring skill mix in primary care is that in practice, skill mix is not something that is static as previously found in the literature, in that there's no such thing as the right clinicians or the right practitioners being able to deal with the right patient. Instead, skill mix is something that should be viewed discursively as a process. From our project, we did an in-depth case studies of 5 GP practices in England. We conducted 29 interviews with staff at the practice and observed approximately 20 hours of observations. This includes GP and non-GP consultations and as well as observations of the receptionist. What we found from our project is that skill mix is about balancing between categorization and adaptability, which I will discuss in details in the next few slides. Our findings seems to echo what Reeve has noted about interpretive medicine, is that general practice is about interpretation of illness. Knowledge is not uncovered, but constructed as the clinician and patient travel together. However, what we also found is that the interpretation and construction is not only between patient and practitioners, be it GP or non-GP, but there's also interpretation construction between patient and receptionist, patient and technology, for example, online triage, and between GP and non-GP practitioners. We found 2 types of categorization. The first is problem or task categorization. GP practices use competency framework or internal directory services or skill mix matrix, which map practitioners' competencies with problems, tasks, or conditions they can deal with. The receptionist in our case study site mentioned that they have a list of each clinician's skill type so they know what practitioners are able to see or treat. However, this is dependent on the individual practitioner's clinical experience and expertise. This GP quoted that sometimes some issues get missed before they get picked up if practitioners don't have an in-depth understanding about what they potentially could be missing. Moreover, practitioners also have broad range of competencies. They have different formal qualifications and different level of practice, and they can upskill themselves. Hence, the broader spectrum of practitioners' competency, the more sophisticated the categorization may become. For example, although you are called advanced nurse practitioners, not all advanced nurse practitioners are the same. Similarly, with physician associates, although physician associates are trained in the same way and the qualifications largely look the same, different physician associates have different standards for themselves and they have their own strength and limitations. The purpose of this categorization is for navigation of the system in terms of which a patient can be booked in with a practitioner for the condition they are presenting themselves with. However, during consultation, there's a possibility that a practitioner that the patient was booked in to see might not be the right practitioner. This was because what the patient thought and conveyed to the receptionist as an issue might not be what was uncovered when the patient discussed this with the practitioners during their consultation. Hence, this requires adaptability. Adaptability on the part of the practitioners. This is dependent on the practitioner's past experiences, interests, and personalities. It also requires adaptability of the organization to be able to adapt to the changing requirements of practitioners and patients. Lastly, it requires the adaptability of patients. Patients need to be able to adapt to the differing approaches by diverse range of practitioners. To summarize, in policy documents, skill mix is conceptualized simply as having a diverse roles and a range of practitioners. In the literature, it refers to a range of competencies and practitioners in terms of ratio of practitioners and the mix of practitioners. Hence, skill mix changes are discussed in terms of role changes. Cunningham has attempted to develop a conceptual model of skill mix, identifying three interrelated elements. They mapped and depicted the relationship between skill mix dimensions and attributes and highlighted the need to take into account contextual factors that influence skill mix, which they argue is often neglected in the literature. In our study, we found that there's no such thing as optimal skill mix, whereby you can get the right practitioners to deal with the right patient. Therefore, rather than adopting a static view of skill mix as has been found in policy documents and in the literature, we argue that skill mix should be viewed as a discursive practice, i.e. as a process, and that this process is reiterative. Thank you for listening.